medial lateral, and this is the start of the ethmoid bulla. So it is a posterior lateral drainage that we need to get into the frontal sinus. This is then going to continue into the supraorbital. Ethmoid bulla is here, and then as we go further back, you will see that the middle turbinate now is starting to turn. The anterior ethmoid on this side is reasonably flush, not very low lying. This is the start of the superior turbinate and the posterior meatus. And then as you go further back, you see now how the middle turbinate is turning towards the orbit, and you have the posterior ethmoid now in your view. As we go further back, we notice that there are 3 or 4 posterior ethmoid cells, and then as you go further back, there is a big posterior ethmoid cell at the back. This is now the sphenoethmoidal recess, and beyond that will come the sphenoid sinus. So this is the start of the sphenoid sinus, this is the end of the posterior ethmoid, this is the orbital apex. How do we know that this is not an Onodi cell? Let's go further back. Okay, so now I'm fully in the sphenoid sinus, and at this point I see the optic nerve. So if I put the pointer on the optic nerve and look at it in the sagittal and the axial part, it's in correlation with the sphenoid and not with the ethmoid. So though we have a large posterior ethmoid, it's not an Onodi cell. Okay? As far as the anterior part is concerned with the maxilla, so that's maxilla. This is the nasolacrimal duct coming into view. So nasolacrimal duct now going to open into the inferior meatus. So exactly at that point you will start seeing the uncinate process. Okay? So now you see let's move this line a bit. You see the uncinate process, and the uncinate process is rotated medially. And you have the opening of the maxillary sinus. And as I go further back, it's a reasonably wide sinus opening in this area. You may have not much difficulty in getting into maxilla.
Mainly anterior posterior ethmoidal.
So as you go further back, there's a possibility that there is a posterior fontanelle as well. If you see where the axial section, it's a posterior fontanelle. Now, this is our first reading of the scan, right? You understand I've only spoken to you about anatomy. Second reading, we look at pathology, and we see that all the sinuses are involved. There is no fluid level. It's more like a chronic sinusitis with soft tissue densities. So for me, this is going to be a CRS with polyposis. Okay? CRS with polyposis involving all sinuses. So we need to clear all the sinuses. Frontal to CRS. The sphenoid is relatively clear but not fully clear. Our third reading of the scan is going to be the risk areas. What are our risk areas? In the morning you heard complications. So we're looking at bleeding, orbit and CSF. From a bleeding perspective, we are looking at the anterior ethmoid artery, which is reasonably flush. We are looking at the posterior ethmoid artery, which is again over here and flush. And we are looking at the carotid artery, which has got a nice bony covering. So I'm not too worried about the blood part. If you look at the orbit, and the axial is a good scan to see the orbit, we see that the orbit has got a nice intact wall here, and though there is some tilting in that posterior area, we don't have too much to worry about. Okay? And third is CSF. So we look at the cribriform plates. There is soft tissue all the way up to the cribriform plates, including the olfactory cleft area. So this is one of those things that we want to depend where the yellow line is. Above that, we are not going to do any debriding. We are going to hope that medical treatment resolves that problem. And as I go further back, I'm seeing the lateral cribriforms and the fovea euphoidalis, and seeing that there is no major bone erosion there. though disease extends all the way to skull base, and I will need to clear the skull base. So posterior ethmoid, I have a little bit of erosion in this area, as you can see, but that's the only part I need to be careful. Okay, so we're just going to wash up. I'm going to do the right side later with you if we have time. So let's do the left side without a rush. If we have time.
হ্যাঁ ওখানে ঠান্ডা বেশি
গোল্ডেন মার্ক থাকলে কি ভালো ব্যাপারটা কি তাই সাধারণত টাংস্টেনের ভাইগুলোতে গোল্ডেন মার্কের উপরে টাংস্টেন সেগুলো কি সহযোগ পায় টাংস্টেন সহযোগ
জি ভাই অনেকক্ষণ করছি
এখন কোন দাঁড়ো তো এইদিকে তো
দুইটাই এগুলো আছে অনেক
তোমার এইটার জন্য আমার ভালো লাগে না ঘুরে
মৌসুমী কাজ করতেছে মৌসুমী
আপনি কোথায় আছেন ভাই আমি ঢাকা মেডিকেলে এসবিতে ঢুকলাম এবার হ্যাঁ ডেপুটেশন আসছে হ্যাঁ ওকে
সিক্স আছে নাকি
হ্যাঁ সিক্স আমি তো ফেজে কমপ্লিট করে গেছিলাম আর কি
Have you any question in auditorium?
ওইটা চলে যাবে
ডক্টর সুমিত স্যার
Yeah.
আপনার তাহলে ফেজেতে জানুয়ারিতে পরীক্ষা দিবেন না এই জানুয়ারিতে
Yeah, but I'm not still close the because you know now after the osteotomy this dorsum has edema. So still when we fix this because now the things are free now, mobile. So in the last when we put the splint and the good steady strip, then the things are still. Because when you left it, then the things are mobile, completely mobile. That's why it appears. And when a patient have a 20 or 25 year, the skin collagen also has a bend on that.
এ রনি ভাই
So it appears. The
রনি ভাই
collagen just come again
আপনাকে
on
কোথাও
the
দেখি না
original position.
আপনি
So
তো
that's
আমাদের
why it
ইতে
appears.
আসেনি না
Because look that the entire body was
Koi,
being mobile. When you put the splint in the straight position, then you have no problem. Definitely you are right, it appear in your screen.
is there any benefit to put some cartilage slash in the medial canthal area?
Yes, we put there just because when we
Kamal bhai.
bony area and the cartilage. So you know, after the letter, if you have some rough part of the dorsum, then letter filled by the patient. So for the better
Hey, tell him.
contour and getting the good dorsal aesthetic line, we always put the whatever amount of the cartilage.
না না এরপরে আর একটাই আছে এদিকে শেষ হচ্ছে এরপরে একটা
Yeah, I show you. Everyone had that in mind, and after the closing,
এই
how high
কমল ভাই তাহলে ই কেটা ভার কখন হবে এই নিয়ে সেটটা হয়ে যাবে এই নিয়ে সেটটা হয়ে যাবে
জানাই
হ্যাঁ
Yeah, one unilateral right side is telegraph. The reason is that two. Number one,
এবার নাকি হ্যান্ড অন কিছু নাই নাকি
then I use bilateral. I
ওই
have
খালি নাকি
benefit
demonstrate
of
করবে?
the cartilage. But if I need, then it's essential. Then I make it multiple. I have
হ্যাঁ জাহিন ভাই থাকলে তো জাহিন ভাইয়ের পরে
But after using the right side long, broad spreaden graft and by my clocking suture, my
Hey.
midfoot is straight. That's why I don't use on one
এখন আর ভিডিও করে কি হবে সোজা তো হয়ে গেছে না
ড্রেসিং ড্রেসিং
ড্রেসিং তো কালকের মতোই দিবে না হ্যাঁ একই ড্রেসিং না আমি খালি আজকে এক্সট্রা পাইলাম কোনটা ওই যে
এটা ট্রান্সভার্স করলো না এইদিকে বাইরে এক্সটার্নাল এক্সটার্নাল স্টেটমি এইটুকু তো এক্সট্রা পেলাম আর তো এটা তো আগের মতোই ও আর ডটসাল তো একটা দিছে মানে এই প্যারামিডিয়ান দিলে এটা এটা
But on the
আর ল্যাটারালটা তো কত কালো করছে
we just make an incision and by my Joseph periosteum elevator, I just go sub-periosteum. Why? The reason behind that, if you make a rest for the bone on the periosteum, then later you have a lot of edema. Number one, you have the less chance of the healing. Number two,
চলো নিস আজকে যা আগে আগে খেয়ে দেয় এসে বসে এবার পরেরটা তাহলে ফুল দেখা যাবে
better produced by this
Anis?
diet cartilage. That's
চলো
why
আগে
I
যা
just
খাওয়া
go
দাওয়া
the
করে এসে বসে পড়ি আবার নামাজ পড়ে
How many days you put the external bandage?
Just on the shoulder. Because you know, the periostome is not exactly.
Another thing is that for resting or osteotomy,
Yes.
You have given a horizontal incision over the lower end of the inferior cabinet. When you do this and
Lower end of the inferior cabinet we just make for lateral osteotomy. For the lateral osteotomy.
is it for only lateral osteotomy?
Only for the lateral osteotomy. There is no other indication. Sometimes if you have a secondary cases that your case is operated 3 or 4 times and if you attend such type of the cases, then because that case has a lot of chance of the hematoma formation on the dorsum. So you can just put a drainage hole. In that case, or the preservation gynecology for making a drainage hole just to make a incision on the anterior. Otherwise, no.
Just the whole head, whole table like this.
So this is my dice cartilage. I remove the excess water.
Super.
This is my dice cartilage. I remove the excess. Give me the white double prong retractor. Give me the white double prong retractor. Yes, white double prong. Now everyone has a query in your mind then how I put it this one. So look that I invert the margin of the HeLa and then look that I have this suture. I have this suture and
বলেন কিছু কি রে ভাই
এই ওটা তো সরাই দিচ্ছে
ক্যামেরা দুইটাই দেখান অর্ধেক অর্ধেক।
And turn the TV a little bit.
ওই যে টি দিতেছে না বোন ওই যে গুড়া কাটিলেস ওইটা না
ওই যে
Okay, in the auditorium, can you hear me now?
yeah.
Do you have a good picture?
Yes, sir.
Give me my section. Number 2 section. Okay, so our first look inside the nose is here. We're on the left side. This is the inferior turbinate, nasopharynx, eustachian tube, lot of mucus in here.
Audiovisual endoscopic view টা দেখেন হ্যাঁ ওকে
Lot of mucus in there. Okay, nasopharynx, soft tissue, middle turbinate. We have polyps in the middle meatus. All the way up. Little bit of a deviation, but I think we should be okay with that. If you look medially again, we have more polyps here. Okay? Alright, so let's start with our surgery on the left side, since we've done the scans on the left side. Elevator. Our first step, of course. Oh, give me packing. So first thing I want to do, just before I do anything else, also is to just develop some space in that middle meatus. Okay.
Hello?
So let's get it between the turbinate and the lateral wall.
Can you please tell us about the local infiltration?
I have done no local infiltration.
It's not required.
I normally am happy with my anesthetist, so I do no local infiltration. If my Bangladesh anesthetist is very good, I take him back with me.
Thank you for the compliments.
So we are just going to put a little bit of the patty in here.
This patty is soaked with adrenaline solution?
Yes. I'm not sure what percentage. (30 cc) xylocaine with 4 ampules of adrenaline. Okay, so this inferior turbinate now I need to fracture. Okay, so you can see I'm fracturing it. It's quite a hard fracture. And then we'll try and lateralize it a bit. So what this does, it gives you a little more working space below. It also opens up your meatus, middle meatus. So now you can get a little more working space here. I'm also going to do a soft fracture of that middle turbinate, just with the patty, to have it as medially as possible. And with a soft fracture, you're not worried of a CSF leak because the mucosa is intact. Okay? Lagging forces. So now we can take it out and see what we have. Sorry. Got many pieces here. So the right material for making these patties is actually soft roll. What we use what the orthopedic guys use for the plaster, under the plaster. We make it from soft roll, so it doesn't break like this. Okay. So now we have a polyp on top, we have a turbinate here, and we have an uncinate process which was medialized, right? Our surgery is going to start with an uncinectomy. Give me a background. And can you bring this trolley close, sister? You go on that side. Go on that side.
খুঁজতেছেন কিছু
Your place to go. Go on that side. And then come. Okay, so when you enter, your backbiter is straight. When you open it, it's straight. Only when you are past that uncinate process, will you want to rotate it into the infundibulum, engage it, and then cut. Okay? So then you make your cuts. Give me a seeker, small seeker. Seeker, small one. Give me a small one. So once I have that done, I'm going to take a small seeker and go into the maxillary sinus, right? So I'm going in and then turning inferior. And then I'm using the shaft of my instrument to break the uncinate. Okay, so now the maxilla is open. I will also just reflect this upper part of the uncinate and bring it forward. Okay, so that's done. Now I can take my debrider. We're going to use a 40 debrider. So when you attach it now, two things. I'll just show you how to attach it. One, keep the opening closed. Closed, not open, closed. And in the same alignment as the shaft. So not like this. Same alignment. Okay. Pull back, close it, click, lock. Okay, whatever we are using, these are the same steps. Now, I would much prefer a 40 than a 0 because it allows me to move my turbinate out of the way and work inside and be able to do the uncinectomy. It also allows me to take out the uncinate in its anterior aspect without damaging the mucosa in front, which can happen with a 0-degree debrider. Okay, so this is the lower uncinate. There is a little bit of polypoid in mucosa attached to that. And that part of the bone we can take out of the faucet.
কিন্তু এনবিএস নাম্বার শুনে দেয় আবার উঠলিবে বাদ দিতে লাগবে বলে টিয়া বেশি খায় মানে জেন মনে হয় এন করতে
Okay, so let's take out that bone.
গুগল না এত বছর ধরে উঠলিবে টিয়া দিয়ে দেয়
Small.
উঠলিবে নামও না জানা
Straight to the front faucet.
যেগুলো কথা বলি না এসে হচ্ছে না যে
So we'll just take out that piece of bone and remove.
বিল্ডিং এই দেই বিল্ডিং এই যেসে আছে
Then we can go back and remove the upper part of the uncinate.
পরবর্তীতে
So this is the upper part. The upper part will then form the medial border of the agar nasal. Can you see this? This is the agar nasal. Okay. Also, I'll just take out some of this polypoidal tissue so that we have a clear-cut definition of our anatomy. I have the bulla at the back. Okay. This is my agar nasal. Are you all following? So I'm removing the medial wall there of the agar nasal, and I can come up to this point. At this point I can't see much now. I also have a little bit of blood. Inferiorly I have the maxilla now open. Okay? Now let's get some hemostasis so that you can see clearly. Yeah, sorry. If there are any questions, please keep asking.
Okay, sir.
I'm just going to put in some. At all times, I want you to understand and see what I am doing. So if there is blood in the field, if there is anything that you can't see or follow, please stop me. I'll go back. We are not in a rush to do this side. So we'll give it 2 minutes, okay? Now, in a normal situation, I would go to the right side and do the same thing on the right side. So I'm not going to waste time then coming back or waiting for this hemostasis to happen. So though we haven't done the scans on the right side, let's at least look at the right side and see what we have on the right side. Okay, so we have a significantly deviated septum here. And there is no way I can do any septum, any fess work without doing a septoplasty. Are we clear on this?
Yes, sir.
Okay, so I'm going to stay with the left side. We finish the left side, we do a septoplasty, and then we do the right side. Okay. So I'm just going to put the patty back in there. And we look at the left side. We'll stay with the left side. So,
Sir, sometimes you are using cotton patty, sometimes you are using medicine. What is the difference?
so normally if I have a thin narrow recess, I will use cottonoids.
Okay.
So that time in the beginning, this turbinate was closer to the lateral wall. So I wanted to create the space by going through a narrow crevice. Now it's already wide. So I can use Merosat. Okay?
Thank you, sir.
Okay. So now you can see the bulla clearly. You see the turbinate. You see the opening of the maxilla, which we will go back to with the 45-degree scope later. Right now I'm not too bothered about it. I see the back end of the middle turbinate and the ground lamella. Okay?
Okay.
Ground lamella. You still have a few polyps here in the medial part. Now I'm going to come anteriorly and see what we have anteriorly. Give me a right angle curate.
কাগজপত্র সব ফরওয়ার্ড করে রাখছি
In my instruments. Where are my instruments? Yeah, this is a right angle curate. Correct, do that. So what I'm going to do is, I'm going to rest my right angle curate on the bulla and I'm going to slide it up.
নাম্বার আছে
When I slide it up,
পিকচারটা দেখান এন্ডোস্কোপি পিকচার দেখা যাচ্ছে না
rest it on the bulla and slide it up. When I slide it up, I'm going behind the posterior wall of the agar.
অসুবিধা না আমি
Okay.
নাম্বার দিচ্ছি আমি
Then I'm going to engage it and come forward.
সাবধানের নাম্বার তোকে পাঠাচ্ছি
So with this maneuver, I'm going to try and take out my entire agar cell
বিউটিফুল
like this. Okay. So that agar cell comes out, and you know on this side is more or less continuous with that type 3 cell. So this is one of the situations, concepts, where you can consider doing a warmored axillary flap. No, doing the ethmoid, please. The same ethmoid concept. No change. Take your time. Do not biopsy. You don't know. One more bone in here.
Sir, you told it is type 3 cell. What is type 3 cell?
Oh. So you have the Poon's classification.
Okay.
So type 1 is one frontal cell above the agar. 2 is two frontal cells above the agar. Type 3 is a frontal cell above the agar which extends into the frontal sinus. And 4, same period. 4 is when it extends more than 50% of the vertical height of the frontal sinus.
Excellent. Thank you,
So
sir.
here we have a type 3, okay?
Oh,
So now I'm going towards that type 3. I'm going to remove that bone here. Okay? So what we have to do to be able to work with a type 3 are two things. One, we have to widen this axilla so that I can look up easily. And two, I will need to use an angled endoscope. Okay, give me that, give that again. So now I have removed the bone, I have some soft tissue here. So let's take out all that soft tissue and see how much of space we got in the axilla. So this is called the axilla, part where the middle terminate attaches to the lateral wall. Okay. So already you can see some polyps which you were not able to see earlier, right?
yes, sir.
Okay. But I want to see still higher up. You have a kerosene punch. So I want to, with a punch, I'm going to watch. With a punch, I'm going to try and widen this part still a little bit more.
Excuse me, sir. In all cases, can we reach to agarnesis cells by this procedure? Just scoop in front of the bulla and.
Yes, that is the right way to do the agar removal.
Thank you, sir.
Okay, so I'm just widening, I'm just removing the last bit of that cell. The type 3 is continuous with the agar, so it's just the continuation of that cell which I'm removing in the upper aspect, okay? And again I will pack it and come back so that we can see clearly. In between we can also do some saline washes. If you have saline which is very warm, then that's better. Around 37, around body temperature. So warm saline works better than cold saline as it promotes coagulation factors. And who told us that? You know, in the past there was practice where the barbers came home, I don't know if it happens now, and they did your beard and shave for you. And when they did that, they would always sit with a bowl of warm water. In case they give you cuts on your face, you always mop it with warm water. So you know that warm water works better than cold water.
Exactly.
Okay. So now we can see up a little better, right? And for us to follow this even higher, I will need to change to an angle scope. So now we'll go to a 45 scope. I can go to a 45 or a 70, but if you go straight from 0 to 70, it's a little disorienting. So we go to 45 first, so that we are well oriented, and then we'll go to 70 if required. No, this is 70. This is 30. So where is the 45? No. Okay. So at the moment we have a 30. Which I cannot see anything. So I think this 30 scope has been abused beyond help. No, we're not getting a clear picture. Okay, give me that 70 because I can't see with the scope.
Sir, you are approaching your frontal sinus by following intact ruler technique.
At the moment. Now, if I have to use a 70 scope, it may not be possible because I need to create space for my endoscope. Okay, so we will check. We will check. If I feel at any point that I'm not able to get a good view, then I will change. I need a bigger image. Just take out this patty. And now I need a big speaker. Throat suction. No, my throat suction. So I like to use my throat suctions. There's a big difference between the regular throat suctions and mine. And you will see it has what we call a keyhole. Can you see this keyhole?
better option.
Yes, sir. So when I put my finger, I can control from here how much suction I want. Right? So when I go into the frontal recess area, initially I'm just using it as a probe with zero suction. So you see I'm here, there's no suction, right? Unless I close my finger and get suction. So I can control it, and I don't want to suck in this area unless I have to. Because suction in this area, especially on the way in, causes the trauma. Okay, small piece of bone that comes out. Now I know my frontal drainage pathway is between the suprabular medially and the ethmoid sinus laterally. Can you see already one opening there? Okay, so give me a seeker now, and with a seeker I'm going to see if that corresponds to my frontal sinus. Okay? But you can see how my frontal sinus, I'm only sucking on the way out, not on the way in. Okay? No suction. Only now as I come out, I can see. So by using this suction in this method, I can get into my frontal without causing trauma. Seeker. Yes, mine. Do you have mine? Yeah.
Hello.
Yes.
What is the symmetric telescope? How you negotiate the telescope and instrument together, sir?
Okay, so now you see my seeker is in the frontal. Okay? Yes?
Yes.
So it is not anything great, it is just understanding your CT scan and using the right instruments. And then from there I can just break, I can fracture laterally to widen it. I don't want to go medially where there is cruciform plate. My two safest places are laterally and anteriorly. Okay? Okay. So now that I have the frontal, I can go ahead and do my bulla and then come back later to widen it. Is that okay?
So now please do saline wash.
Sorry?
Saline wash.
Saline wash, yeah, okay. Give me a bigger cannula. Something which has no hole. Yeah, can I use? Or give this is better. Then do the wash. Yeah. Yeah, I know that it's a little dark in there, but that's the same situation we are facing. Okay? Frontal clear, 70? Okay. So all this polypoidal part for me to clear, I need approach from here.
Sir, in case of saline lesion, which fluid is preferred, sir? Normal saline or Hartmann solution?
Normal. So unless I remove my bulla, I can't continue using an angle scope. Okay? Now since I have the 70 in my hand, I'm going to rotate it to see the maxilla. So now we are looking inside the maxilla. And you can see that it's reasonably clear. Okay? This suction has stopped working.
কন্ট্রোলের পলিপ তো নাই,
না না, ওই যে অ্যাকান্ডেজের ওখানে যেটা,
ও বুল্লা
না না, অ্যাকান্ডেজের ওখানে ছিল না, অ্যাকান্ডেজ পুরোপুরি ক্লিয়ার হয়নি তো মনে হয় এখনো।
ও সামনে কিছু নাই তো আর, পিছনে শুধু বুল্লার পাটটা আছে।
Give me your suction right here. No, this is. So I'm using a suction I'm not comfortable with, but.
এই সাকার তো জিরো সাকার নাই, আচ্ছা এটা তো
Okay. So we have a little more of this maxilla which I can widen. So this part of the uncinate we need to take out. Give me a point.
70 ডিগ্রি দিয়ে ধরছে নাকি?
So there is some bone within it, so the divider may not work very efficiently. So let's take out that bone first.
কি দিয়ে ধরতেছে এটা?
And now you can give me the divider.
ওই খাবার দিছে তো, খাবার দিছে, খাবার দিছে। এই ফেস শেষ, দেখার কিছু নাই।
Okay, so now we have a nice wide maxillary sinus coming all the way anterior to the normal maxillary osteo. And reasonably posterior. We still have good mucosa around the edges, so we don't need to do any more. We now will convert back to a 0. 0.
পজিশন কিন্তু আপওয়ার্ড করা নেই, তাই না?
টনসিলের পজিশন অনেকটা, টনসিল আরও ডাউন হয় কিন্তু এক্সটেন্ড তো নেট
I want
এক্সটেন্ড।
30 degrees, but I want the table down. But if I take this up, I'm working like this. What? Change. That's you. Thank you, Dr. Okay, we go back to a 0, and now I can do like hemorrhoidectomy.
Sir, what is the position of patient, sir? You send back under the shoulder or not?
Yeah, so we have the neck a little bit extended. Okay? Little extension. And normally I want head up. Head up by 25-30. But the problem is this table doesn't go down. So already it's quite high for me. If I take the patient head up, then it becomes too high for me to be comfortable. If I can get a little head up without and the whole table goes down, you will get better hemostasis. But unfortunately, I then have to stand on a platform or something to work. Okay, is that clear? And this endoscope and camera will be in my mouth. I'll be having something else for lunch. Okay.
ও ভাইয়া আমি একটা দেখাইছিলাম না সিরি দেখাইছিলাম না টুবিকম প্লেটের ওই দিক দিয়ে আমাদের মেনিঙ্গো যখন বসে
There's some water elements.
নিউরোতে পাঠাইছিলাম
It's
ওরা
water.
মেনিঙ্গো
Right.
বলছে ব্রেন ম্যাটার নাই
Fully dry.
শুধু মেনিঙ্গাস ইয়া
Be
করছে
careful.
মেনিঙ্গাস নিয়েছে ওরা
Dry cotton. You know dry cotton?
আপনারা করছেন
That's good. See, if you use more non-dense, you're going to
মিনিট ফোরে নাকি অনেকগুলো করছে ওরা
always use cotton.
ভালোই করতেছিল আমি তো চোখেই দেখি না ব্রেনে কিছু নামছে এটা শুনলেই তো ভয়ঙ্কর ব্যাপার
Okay, so you see the difference in the image once we wipe the lens. Okay. Now let's take out this fatty nervous cell piece and we'll do an ethmoidectomy. So are we clear so far? Maxilla below, frontal above, right? Listen, we're going to do an ethmoidectomy, debrider. So we can do ethmoidectomy many ways. We can do it with a debrider, we can do it with a curette, we can do it with an instrument by opening the anterior wall. If the bone is hard, then I will not be able to use the debrider. If the bone is soft, I can use the debrider. So I'm just going to check with that. Okay? Sorry, I lost my.
ওরা কোথায় দৌড়াই
So I'm just going to check with the
বাসায়
debrider if the
এটা
bulla
আবার
is
দেখবে না
soft enough.
এত সকালে ইন্টারেস্ট হারাই
Okay, just all the polyps coming out from next to the turbinate. Okay, so we've gone into the bulla now.
এইটা বললা পুরো পুলা মারা দিচ্ছে
Bone is not very soft, it's a
Bone
little bit
is
hard. And that for me is a little worrying as I go laterally towards the orbit. Because I don't want to use too much pressure laterally. Okay, these are all some polyps within the bulla which are coming out.
ব্লাডি ফিল্ডে সবই ভালো আছে না এই ইয়াগুলো সব আলো ইয়া করে নেই পানি
Give me a zero.
না না
I'm just going to change to a zero
Nah, make it
divider until we get this 40 clear. So we still have a little bit of the wall of the bulla.
ভালো বলি
মেডিকেলের কাছ থেকে ব্লাড টেস্ট মোটামুটি
তো ফেসে লোকাল দিছিল দেয় না একগুলো লোকাল তো
লোকাল তো দেয় না এখন সব মানে এটা তোমার ইয়া করে ওই যে তোমার পেটি দেই করে সবাই লোকালে তো রোল আর হচ্ছে রোল সেম রেজাল্ট
পোষানো তো কঠিন আর কি দিয়ে যদি দেন তাহলে
লিডল স্পাইরাল দিয়ে
নর্মাল লেভেল তো ঢুকবে
না নেভার এভার দরকার তো নাই কোনো দেয় না কেউ আপনাকে
If your debriders open when you go to come out, it sucks from the mucosa and causes mucosal trauma.
লোকাল পার্টি
So your debrider blade must always be closed. You never want it open.
সারফেস
When you go in or come out.
আরে বংশের মধ্যে দিলে তো আটকে যাবে আটকেছে না কেন
When I use a zero,
না
you see,
বোনস আসতেছে না
to go to the lateral parts is more difficult where I don't have the angle. So if that 40 is clear, then I'll go back to 40. It's more comfortable for 40.
তো জিরোতেই
So we are starting off by doing what is called a low ethmoidectomy. I'm not going to the skull base here. Are we good with this?
মেরোসেন ড্যান্সার
Well, everyone is enjoying this. Enjoying. Nobody taking lunch.
বাট ফিল্ড ইজ ব্লাডি
Okay. So you see with a 40, it's so much easier for me to work on the lateral part, right? Without putting pressure on any bone immediately. These are all some bone pieces of that ethmoid. And here I am at the orbit. Can you see now?
আমি তো সব কোয়ালিটি
At
দেখতেছি
the back, we are at lamina.
Later one is lamina.
Yes, this is the orbit. So when you reach the orbit, of course, you don't want to use the debrider in that direction. Now here, we are going to go towards the ground lamella into the posterior ethmoid. Now for me to do that, I have to go back
the
towards
medial.
zero blade.
লেমিনার প্রেশার দেখা যাচ্ছে ওই উপরের দিকে দেখা গেল বুঝছস না আর নাই
Okay, let's get a wash so that you all can follow what I'm doing.
মিউকোজাল ইয়াই দেখতেছি পলিপের মতো
উপরে
উপরে ছিল না।
আপে করা যাবে না আর ঘুষাতে করা যাবে না আল্লাহ
Yeah, wash.
এরা যেভাবে ভয় দেখায় যে ল্যামিনা ব্রিজ করলেই অরবিটে চলে যাবে মানে এতই কি আসলে ইয়া
লেমিনা ব্রিজ হতেই পারে লেমিনা ব্রিজ করতে ফ্যাট টানাটানি করবা না তাহলে তোমার কিছু হবে না
সেটাই তো আগে তো ফ্যাট আসবে অরবিটার ফ্যাট
So
আসবে
we have the maxilla laterally.
লিগামেন্ট না ইয়া
You know, we have ground lamella all the way coming up. Ethmoidectomy anterior, the lower aspect is done. Give me a ethmoid forceps. Let's take out all
অ্যান্ড্রয়েড
this.
পার্ট শেষ মানে করতে হবে গ্রাউন্ড লেভেলে কিছু পার্ট আছে না আছে
Not with me. Not with me.
উনি মিডিল ট্রাগনেটকে আউটফাচার করেনি না
না
মিডিলাইজ করেনি
These instruments can just keep it in front of
ওই যে
you.
জাস্ট ইয়া দিয়ে খালি একটু
We need two instruments most of the time. Keep this right in front.
প্যাটি দিয়ে খালি একটু চাপাইছে
So we'll just take out whatever loose bone is
ইয়েস
there.
স্যার বাংলা মাধ্যমে চলে আসেন স্যার এক্স্যাক্টলি
Okay.
আটাই দেখাবি না
Give me a
প্যাটি
packing.
দেখাবি
Yeah, okay. So let's again just put a little bit of packing inside just to clear the blood and make the anatomy more apparent. And though I'm doing this more because I want her to see clearly, it's always a good idea to work with proper vision. Keep the field as clear of blood as possible. Also, then your image will not get dark. Okay, maybe we can try a
সেফ
little bit more.
সেফ সাইডে থাকাই ভালো কারণ টার্মিনেট মার্মিনেট যে এরকম টকটকে লাগ ইঞ্জুরি একটু তো হয় স্প্লিন্টিং দিয়ে দিলে ভালো অনেক রুগী সাইনিকা পাওয়া যায় আসলে ফলো আপে যখন আসে
Generally, I tend to use more cottonoids than Merocel because I can work it like this. This is easier to work than a Merocel piece. I can put pressure in the areas I want, I can move part of it, I can check behind. So it just works a lot better than Merocel pieces. Okay, so now you can see the ground lamina clearly, right? Yes, are you okay with that?
মানে পোস্টেরিয়র রিট মারা দেবে
Ground lamella.
পিছনে তো এটা নিয়ে তো শেষ
I think we've lost audio with the auditorium.
No.
নো স্যার উই আর
Audiovisual, can you check? I don't think auditorium can.
ওয়াচিং
Okay, sir. Sir, everybody is enjoying your service.
But if I'm not getting response, I think there's an audiovisual problem.
No.
No, sir. Okay, sir. Now you please demonstrate the anatomical landmark at present.
Middle turbinate,
Yeah.
maxilla laterally at 4 o'clock, ethmoid, ground lamella, frontal above. We are now going through the ground lamella into the posterior ethmoid. And the back is the orbital apex.
ওটা
Okay, and then from posteriorly we are going to go superiorly towards the skull base. Where is the skull base? How do I know? I know the skull base will slope superior to inferior as we go from anterior to posterior. Correct?
এখানে স্কালপেল ইনজুরি আর কোনো পসিবিলিটি
Correct?
নেই
Correct, sir. So now I want to check. Do I need, is this skull base already or not? Correct? At the back.
সবথেকে তো থিক পার্ট এখানে পোস্টেরিয়র রিপ মডেল আর এটির অবস্থান
Just
কোথায়
remove a little bit of this partition.
মডেল তো সামনে পোস্টেরিয়র রিপ মডেল এই জায়গায় না
কি আর্টারি
আর্টারিটা
এক্স্যাক্টলি এটা হচ্ছে যে এথমোড
And when I do that, I should get a view of the superior turbinate.
মডেল রিসেসের ওখানে
Okay, can you see superior turbinate now? Okay,
ফন্ট
this is superior turbinate, where you have more polyps now going towards the sphenoidal recess.
ফন্টটা
This
রেখে যাবে
superior turbinate inferior part we are going to remove.
অ্যানাটমি ক্লিয়ার না
Okay,
আর একটু জুম আউট করলে
not the superior part, no, only the inferior part. And this is called an intermediate approach to the sphenoid sinus.
হ্যাঁ ওইটা মনে হচ্ছে
Which one is your preferable approach, sir?
When I have polyposis, I will use this same approach.
That is intermediate approach.
Intermediate. When I have no polyps, only CRS, I will use a lateral approach. And if I have only a sphenoid isolated pathology,
Then
I will use a medial approach.
Okay.
এই খালিদ ভাই চলেন হয়েছে বন্ধ করা যায় মোটামুটি সবই হয়ে গেছে অ্যান্ড্রয়েড মডেল পোস্টেরিয়র মডেল স্ফেনয়েড
So now from here, we should be close to the sphenoid sinus, right?
এটা তো স্ফেনয়েড
Clear? This is the maxilla. Back end of maxilla corresponds to the sphenoid sinus. Inferior half of superior turbinate corresponds to sphenoid sinus. Okay? Now if I look from here, I'm about 1.5 centimeters from the coronal arch. And in this case, it didn't matter to me whether I went medial or intermediate, because I still need to go here to clear these polyps in the inferior half, right? So we can still further confirm that we are in the sphenoid. Can you see that?
Beautiful.
Anterior wall. Okay, so we're going to take out a little bit of this polypoidal thing, but not go in this upper half. This polyp we can take out. We'll just take out a little bit.
Polypoidal sense.
And then we can set it up back. So wherever it is stuck, let it remove it.
সাইনিকে হবে না এটা তাইলে এটা রিমুভ করার দরকার আছে
And never turn your divider towards the
এটা
fibriform.
তো আমি র করে দিলাম ওরে তো আলটিমেটলি ফেস করার পর
আমার
আমি
তো
মিডিয়াল
মিডিয়াল পর্যায়ে সাইনিকে বেটার হবে ওইদিকে সাইনিক এদিকে লাগে থাকুক কোনো সমস্যা নেই ওইদিকে না গেলে হলো
তাহলে আর কি তাহলে র করে দিলাম দুইটা
হ্যাঁ র করে দেওয়া যায় তো কোনো সমস্যা নেই এই র করে দেওয়াকে বলা হয় গ্যালভানাইজেশন কি বলে ভালগারাইজেশন বলে আর কি ভালগারাইজেশনটা উনি প্রিফার করে না উনি স্টিচ দিয়ে দেয়
সব বলতেছিল অবশ্য
So we can do from a little bit of
এটা কিন্তু পার্ট অফ দ্য
not higher.
সুপার ট্রাভেলেন্ট
So my sphenoid ostium is my landmark. That I cannot go above that. Above that landmark is the olfactory fibers. Okay?
ম্যাক্সিলারি যে রুফ তার
বরাবর উপরে আমি এক ফোঁটা করতে পারি
স্পেনার পাবো
না এটা স্পেনার পেতে পারো বা তুমি ইয়াও পেতে পারো
So,
এথনয়েড
পোস্টেরিয়র
once we are inside the sphenoid sinus,
একটা দেন ছিল না যে ম্যাক্সিলারি
we
রুফের
can then have already an
উপরে থাকবে না
idea
স্ফেনয়েড
of where we are in terms of anatomy.
নিচে থাকবে না, উপরে থাকবে।
এটা উপরে মনে হচ্ছে একটু আর একটু নিচের দিকে খায় না
মেজলা ব্লকের লাইনটা
I'm just going to widen that
উপরে
ostium
থাকছে এটা বুঝছো ব্যাপারটা
like we did yesterday, just on both sides. Because I want to be able to see it from laterally as well.
এটা যে যেটা তুষার কান্তি যেটা করে এখানে পেটে দিয়ে রাখি ওদিকে দেখবে আর কি পেটে এনে পেটে দিয়ে রাখবে, কখন পেটে দেখবে দিকে দেখবে, তো হচ্ছে খুব ভালো পদ্ধতি, আমি এটা ফলো করি এখন এটা।
Okay, so you saw
চলে আসছে
my elevator now in the sphenoid sinus.
Exactly.
When I take out this remnant of this superior turbinate, we'll then have communicated a posterior ethmoid with the sphenoid sinus. This was that big posterior ethmoid cell that we saw on the scan.
Yes.
Do you have a through cut forceps? Straight through cut. Nice. See here. Through cut.
এই সর্বনাশ, আমি তো মনে হয় টোকেন নিয়ে আসিনি আইস, আমার খাবার দিবে না?
বাপটা দিবে, বাপ দিবে।
So I'm going to come out. I'm going to take out my elevator. I don't need it now.
কি বললি তুই?
Know where it is. Hold it.
টোকেন
So you have widened the sphenoid sinus ostium with your elevator.
Yeah. Okay. So we need to be right there is the sphenoid. We just need to widen this. So I'm going to use a through cut forceps
থ্রু কাট দিয়ে কেটে দিয়ে
to
যাবে।
take out that back end of that.
আচ্ছা আচ্ছা,
So
এটা ভালো লাগে না।
এটা কি?
থ্রু কাট করছে
না এটা ভাঙতে গেছে কোন জায়গায়?
এই যে ইয়ে গ্রাউন্ড লেভেল আর
this sphenoid has been pushed inferiorly by the posterior ethmoid.
সরি ইনফিরিয়র পার্ট অফ দ্য পোস্টার পার্ট।
But
তাই কি?
that you have to tell other people.
মারে মা, আমি তো ভয় পেয়ে গেছি যে
Okay? Sphenoid. So give me the straight divider.
ডক্টর ভালো লাগছে না, এটা কষ্ট হয় যেতে হবে। আমরা এভাবে করি, উনি এভাবে করলে হবে।
In that area, I'm safe.
মিডিয়াল অ্যান্ড ইনফিরিয়র।
So now you see we have a nice wide sphenoid, right?
Beautiful.
Once we get control of this bleeding, you'll get a better view inside. Give me a kerosene punch. I can still further widen it in an inferior direction. So I'm just going to do that.
কোনটা নিচে আছে অনেক,
So we
নিচে
take a
তো
kerosene
এটা তো
punch on something on which the debrider can also sit. Okay, for the moment we are okay. I don't think the patient head goes up anymore. Okay, but now you have a good view inside the sphenoid. What you see right in front of you is the cella. Okay? And we try and show you optic and carotid later. First, let's concentrate on what we have to do. Give me a ring.
পোস্টারটা এখন ওপেন হয়নি মনে হচ্ছে।
My instruments. Is there a ring here? Give me that. So I'm using a wide curette now, okay, ring curette. You don't want a very narrow curette. With this, I can sort of check. I can palpate and check. Is there more bone or not? Can you see my ring curette going in?
Yes, yes.
And I can just fracture the bone. Not scrape the bone or scrape the mucosa, just fracture. Fracture and remove. And I can see where the skull base is. Now with a wide curette, even if I was to expose dura, there is less chance of my cutting dura as against using a thin, narrow, sharp curette.
Okay. So you should take a very wide curette.
Yeah, same principle as in mastoid surgery, right?
Okay. Larger barrel.
Larger.
For
Okay.
safe treating. Okay.
So now you see it's sphenoid and you see that big ethmoid cell above it.
ভালো কথা বলছেন, পোস্টারে যাই।
Okay?
Okay.
Okay. Give me the divider.
পোস্টার ইটমাটা
Now I know my optic is not related to that so much as it is to the ethmoid, to the sphenoid. So I can take a little bit, but of course I will still not point it laterally. I just want to see inside clearly. Okay?
Very beautiful.
Now from there we keep going superiorly. Do that again. So instead of taking a debrider and pushing up here, which is a little dangerous because the bone is little hard. If the bone was little soft, that would have been okay. Now if my skull base is over here, posteriorly, the anterior skull base has to be at a higher level than this. Simple.
Exactly.
Correct? So I know that this part cannot be skull base. So I'm trying to get in here so that I can fracture the bone. Okay, so we're just fracturing bone.
Beautiful.
And you want to just get a leverage in fracture. I don't want to scrape the skull base, but then I'm going to take the mucosa out. Whether I take the mucosa out or not will depend on whether it is polypoidal. In most situations, even with polyps like this, we try and save the mucosa upward. Okay. Keep the divider 40, right? So now you can see our base is getting higher, right?
Yes,
Skull base is getting higher. We still have not reached the skull base in the anterior aspect. I still have one cell here, posteriorly. Can you make out?
Yes, sir.
Yes, good. So let's clear a little bit of this polypoidal tissue, and then we will look at communicating that. Also, never lose sight of your debrider blade, okay? So you never do something like this. Your blade must always be under vision. Or just keep a wash ready, so whenever the thing comes, so this is all polypoidal tissue here. Also in the morning, I remember I told you when there's bleeding, one of the things you can do is open spaces. So that's what we are doing, allowing the blood to now trickle back. And now you can see I'm getting to the skull base.
Exactly.
This is all orbit. Okay, wash, wash, wash. Okay. So now let us assess what we have left and see which areas we still have got to go higher. But because it's polyposis, you want the skull base defined all the way from anterior to posterior. Okay?
Okay.
So now we have skull base in this anterior part and in the posterior part. So I know there's a cell here, right? Curate.
So would you please show us the first olfactory neuron area?
I hope not. Okay, so you saw that's the cell that was waiting to be removed. Now once I get this out, I'll see the skull base. Upward. Okay, bone comes out.
Hello sir.
Yeah.
Will you please show us the location of the anterior and the posterior equatorial artery?
Yeah, we'll show you. But first we need to get the skull base. Without getting the skull base, I can't show you. Change to 0. So now we have few couple of bony partitions that are still coming in our way for the skull base. Okay? At the back, for sure we got skull base. Here we got skull base. I have one partition here. I have one partition here. Can you see this?
Yes, sir.
Okay. So we need to take out these two partitions. Give me upward. Upward, please. Upward forceps.
এমন করে করলো
Just keep these two instruments in
সে
front.
স্যার ভয় ধরা দিল
Please don't confuse it so that every time I don't have to search.
তুমি যেভাবে শেষ করলো আর ভয় পাই যাচ্ছে
ব্লিডিংয়ের কারণে আচ্ছা কোনো সময় হাই কোনো সময় দেখিনি যে আপনার